the role of specialized geriatric services in acute hospitals is particularly pertinent with regard to the sustainability of our healthcare systems. Major restructuring has taken place with a decrease in the numbers of acute beds, a decrease in length of stay, and also more ambulatory care services being necessary to look after these sicker patients. However, there hasn't been the concomitant increase of resources in the community, and therefore we have problems compounded by an aging population. This is a worldwide phenomenon, and in Canada it particularly affects the numbers of those over the age of 85, who of course have the greatest utilization of our healthcare services. There is concern regarding the current management of the frail elderly in acute hospitals, and in the United Kingdom a press expose led to an inquiry entitled Not Because They Are Old, which highlighted major issues such as dissatisfaction with care, concerns regarding the physical environment, staff shortages, problems with interactions with staff, and concern about the training and education of staff to deal specifically with the problems of the elderly. Poor discharge planning was noted, as was inadequate access to the very necessary community services. Now, the acute hospitals are the most costly sector of the healthcare system, and those over the age of 65 have the highest utilization. In British Columbia, 2/3 of those beds are occupied by patients over the age of 65. Unfortunately, hospitals lead to a risk of functional decline, increased length of stay in the frail elderly, and also an increase in the numbers of those who require long-term care placement. One can say that the acute care setting works more for the benefit of the providers rather than for the needs of the client group, and it forms a hostile environment with poor designs and services based on the needs of providers, which cause a cascade of dependency, leading to functional loss. And in about 1/3 of patients over the age of 65, there is a loss of function in at least one ADL after admission to hospitals. Iatrogenic disease is prevalent, and adverse drug reactions are very common, particularly in cases of polypharmacy, which is very frequent amongst the elderly. Nosocomial infections occur, and about half of these are in those over the age of 65, leading to an increase in costs and length of stay. And delirium has a prevalence of between about 15 and 22% amongst the elderly, and malnutrition is unusually common and often neglected. Now, a major factor in overcoming these problems is the role of specialized geriatric services. And the fundamental premise of these is that much of disease, disability, and dependence is preventable or treatable or manageable. And the problem is, if an inappropriate diagnosis is made at the start, then this will lead to a series of problems with inappropriate treatment, ending with increased length of stay and premature placement in long-term care facilities. In Ontario, regional geriatric programs have been set up at the 5 health science centres, and these provide a coordinated and comprehensive range of multidisciplinary services. There are 6 core services with acute geriatric units internal consultation teams, geriatric rehabilitation services, day hospitals, specialized clinics, and most importantly, community outreach programs. These have resulted in decrease of length of stay in acute hospitals and also have led to other benefits. One of the problems, of course, is that there are not enough geriatricians available to provide the services, and recruitment and retention are ongoing problems. In the United Kingdom, there have been a long history of excellent geriatric services, and these are now provided both in the district general hospitals and in the teaching hospitals. They have three different models. One is needs-related, based on the common geriatric problems. Another model, which is the most frequent at 54% of services, according to a survey carried out by the British Geriatric Society in 1993, is age-related, which takes all patients, usually over the age of 75. And the third and less frequent model is that of a multi-consultant team, of which the geriatrician is just one member. In the United States, the acute care of the elderly units has been a common method of handling this problem. And these focus on preventing the dysfunctional syndrome and has patient-centered care in a modified clinical environment with multidisciplinary assessments, interdisciplinary teams doing joint rounds and working together in joint discharging planning. And these have been found to be beneficial. An older model in the United States has been the Geriatric Evaluation Unit, and a review of the effectiveness of this by Rubenstein some years ago on a veteran population, which is somewhat different from the usual population of the frail elderly, found a lower mortality rate, decreased discharge to nursing homes, an increase in functional status, and less time spent in hospitals. This has been confirmed, the value of these services have been confirmed in a comprehensive geriatric assessment, a meta-analysis of controlled trials by Stuck et al., which found that geriatric evaluation programs with strong long-term management improve survival and function. And another study in 2002 in the New England Journal of Medicine showed that a controlled trial of inpatient and outpatient geriatric evaluation and management, again in 11 veteran affairs centers, showed that geriatric care, though it didn't have a significant effect on survival, did prevent functional decline, did show an improvement in mental health, and very importantly, particularly in the United States context, showed no increase in costs. I think, therefore, the value of specialized geriatric services in acute hospitals is very clear, and there is a target population of the frail elderly who benefit most from these services. However, geriatric services cannot be available to all the elderly in acute hospitals, and therefore there is a parallel role for specialized geriatric services to act as advocates and through consultation, education, change the environment so that it provides senior sensitive services. And the concept of elder-friendly hospitals has been introduced. And I think it's very pertinent that ACE unit philosophy should be available throughout an acute care setting. And those at risk can be identified through such means as the hospital admission risk profile. And having identified them, then preventive measures can be put into place to prevent the deconditioning that occurs through bed rest and immobility, as well as other measures. And such other measures include trying to decrease the risk of adverse drug reactions, and the Canadian Medical Association has some guidelines appropriate to this. Nosocomial infections need to be cut back by good infection control, universal precautions, decreasing the use of catheters as much as possible, decreasing the use of intravenous fluids, and with good skin care. There are certain particular areas which require attention, such as falls and delirium, and there are excellent guidelines available to help in this respect. We must also remember that nutrition and hydration often are overlooked in the frail elderly, leading to unnecessary complications. From an overall point of view, there is a need for advocacy for a comprehensive approach to the care of the frail elderly. So often such approaches are disease-specific, whether that is Alzheimer's disease or stroke, and we need a national service framework for older people. Such has been introduced in the United Kingdom, which has appropriate standards, service models, and most importantly, accountability for the delivery of these. In summary, the current method of management of the frail elderly in acute hospitals leave much to be desired. Indeed, they provide an environment which is detrimental to the care of the frail elderly. Specialized geriatric services go a long way to prevent such deterioration, and combined in parallel with a role in turning the whole hospitals into more senior sensitive environments, there is a lot that can be done to prevent the tidal wave of the frail elderly, which otherwise will overwhelm our current healthcare system. Thank you.